Moving on to the next session, and inside it, but it has got two parts. And inside its part one will be chaired by Dr. Mohanan Nair, Senior Consultant Physician and Diabetologist from Trivandrum, and Dr. Sunil Prashok, Consultant Physician and Diabetologist, Government Medical College, Kollam. Over to you.
Good morning, everyone, and welcome to the next session, which is termed Inside Edge. And we have three eminent speakers in this particular session. All of them are both nationally and internationally reputed academicians. And also I have my co-chair, Dr. Sunil Prashok, who is the most promising and upcoming academician in the diabetology and general medicine in Kerala as well as in India. And I am very happy to introduce Dr. Sreejth and Kumar. Actually, this session has three topics. One is very relevant topics. First is reversal of diabetes possible? And conducted by Dr. Sreejth and Kumar. And second is on cholesterol, the good, bad, and the ugly by Dr. Balachandran. And finally, the third session is going to be by Dr. Jothydev, who is going to speak about the perils of non-evidence-based therapies in this particular COVID era. And moving on to the first session, Dr. Sreejth and Kumar. The name of Sreejth and Kumar is actually a household name in all the families of doctors. He is well known amongst all the doctors, not only in Kerala but in India, because he is a very, very leading figure in Indian Medical Association. He is currently the director and CEO of the Diabetes Care Center in Trivandrum. And he was the former president of Kerala State Branch of IMA, and he is holding very enviable positions in National IMA. And currently, he is a member of the Central Working Committee, and he was the founder of the innovative patient care scheme in IMA. And he is also the chairman of the INDEC, that is IMA Network for Trauma and Emergency Care. And most important of all, he is the national chairman of IMA Medical Students Network, spearheading all the the struggles that are going on the current issues in on medical fraternity and medical profession currently. And he was also formerly a member of the Kerala Medical Council. And added to that, he is an ex-major in the Army Medical Corps. And over to my dear friend, Dr. Sreejth.
Thank you very much, Mohan sir. It's indeed a great privilege, actually, to get introduced by my own elder brother. So thank you very much. And at the outset, let me thank Dr. Sabir for this very kind invitation. It's a great opportunity, and thank you very much for that. Over the next 15 minutes or so, let's talk about this concept of reversing diabetes. At the outset, I should tell you that this is not something new, and I had presented this maybe at least 2 or 3 times in the past 1 or 2 months. And for some of you, it may be a repetition, but what I plan to do today is to go a little slow and just touch upon the 4 or 5 important slides and take home this concept that yes, type 2 diabetes is reversible for those who care to reverse that. So, in 450 years before Christ, Hippocrates told that food be thy medicine. And in 2017, this very famous trial, the direct study published by Mike Lean and Roy Taylor at the International Diabetes Federation, which was conducted in primary care, and they primarily targeted weight management. So they took nearly 300 patients, and half of them went in for the best drugs, and half of them went in for 800 calorie diet. And with this 800 calorie diet, they started bringing down the weight. And what they found was to look for a remission of diabetes, whereby they meant that the HbA1c should stay less than 6.5% without any drugs for at least 2 months. So that is what they called remission of diabetes. And this is what they got. So in those patients who achieved some weight loss, so that means in the intervention group, 46% overall did not require any drug for managing diabetes. And if they had lost more than 15 kilogram weight, then 86% of patients did not require any drug. So they told that remission of type 2 diabetes is a practical target for primary care, and this was a big revolution. And if patients had lost, we told that more than 15 kilo, 86% went into remission. More than between 10 and 15, 57 kilo. So put together, if a patient has lost more than 10 kilo, the chances of going in remission was around 73%. 73% of them did not require any drug. So they concluded that type 2 diabetes is a complication of weight gain and excess body fat, and it is not necessarily a permanent condition. I think that still we are a little slow to accept this very, very important fact that if people are going to maintain their normal weight, characterized by their normal waist, then the chances for diabetes itself disappears. And even if they have had the onset of diabetes, they can go back. So almost half with early type 2 diabetes can achieve remission. And this was, mind you, done in primary care settings. So this became hot news that type 2 diabetes is not for life, and that was in 2017. And then we started discussing this about remission. So what is actually remission? Is it that diabetes is permanently cured? No, it may not be. For some people, it may not ever return, but for few people, it may return. But one thing is for certain, and that it is possible. So if a A1C of less than 6.5 can be maintained for 1 year without any diabetes medication, it is called partial remission. If the A1C can be kept less than 6%, it's called complete remission. And if it can be maintained for more than 5 years, it's called prolonged remission. So by remission, it is not that we don't mean that it goes away for life. Maybe it is true for some people, they may not ever have it in their life. But for most people, at least for many years, we can postpone that. That is one thing. And second thing is that even for those people who need to take drugs, the dose can be drastically brought down. So there are a lot of medical benefits of diabetes remission. It removes the need for drug treatment for diabetes. It controls a lot of cardiovascular disease risk factors like blood pressure, lipids. All these get normalized, and there is a likely reduction of microvascular complications. But for that, logically, it sounds appropriate, because when the blood glucose go down, the microvascular complications go down. But for evidence, we'll have to wait, because this is a new approach. So how do you reverse diabetes, or how do you make remission possible? There are possibly 3 mechanisms. 1 is bariatric surgery, 2 is low calorie diet, and 3 is carbohydrate restriction. So let me tell you that these 2 are different methods. There is one method which is carbohydrate restriction, like you don't count too much on calories, like what you do in, for example, in a keto diet. And then a low calorie diet where you are actually bringing down the calories, and then bariatric surgery. So in a keto diet, for example, you are only restricting carbohydrates severely. You are not actually bothered about the total calorie consumption. Whereas in a low calorie diet, you are bringing down any form of calorie, and bariatric surgery. So any of these 3 mechanisms can reverse diabetes, and you see that the effect is almost the same. If you use any of these mechanisms, you can see the reduction in A1C. Of course, reduction in weight is definitely much more with surgery than with lifestyle intervention, but reduction in A1C is the same even if you do a surgery or you go for a dietary intervention. So that means that our dietary intervention is as effective as a bariatric surgery, and isn't that something very great? But then there are some people who argued that, okay, 2017 direct study got published, but maybe it is just a temporary phenomena, because we know that such things cannot sustain. So what happened then? They followed up these patients for the next 2 years, and in 2019 they published the 2-year follow-up study, and this is what they found. So initially 46%, that means 68 of the initial 149 people had achieved remission in the first phase. And when they followed up for 2 years, they found that 53 of the 149, that means 36% of the original population, still remained in remission. And look here, even those patients who were not in remission, there was at least 50% reduction in the use of diabetes medication. So 1/3 with early type 2 diabetes achieved long-lasting remission was their conclusion, and they told that it's not type 2 diabetes is not necessarily a lifelong condition and is reversible by weight loss. Not only that, blood pressure, lipids, quality of life, adverse events, everything have a favorable outcome. And Mike Lean told why it happens. So he told in this famous editorial in Nature, he commented, type 2 diabetes, its dominant cause is weight gain with ectopic fat accumulation in vital organs. So that is very important. So fat accumulates in ectopic organs, most notably the liver and the pancreas. And this long-term weight loss maintenance, and this produces, and that is reflected by large waist circumference. So if someone has large waist circumference, it's not innocuous, it's an indicator that there is excess fat in his liver and pancreas, and that is causing type 2 diabetes. And if long-term weight loss maintenance is possible, then at least half of the patients can go in for remission. So now let's come to Indians. A waist of less than 90 centimeter in men and less than 80 centimeter in women is ideal. We know that our huge majority of our population, a recent study in Kerala had shown that up to 76% of women had abdominal obesity. And we think that, since everyone has that, maybe that is normal. No, that is not normal. And unless we start targeting that, there is no way we can reverse this epidemic. An exponential increase in diabetes and other lifestyle disorders. So we know that when the waist circumference increase, there is lipid accumulation in organs. I already told that liver, pancreas, muscles, heart. Liver exports too much glucose and VLDL. Muscle fail to oxidize glucose. That means there is insulin resistance. Pancreas, first phase insulin response is lost. And all these lead to type 2 diabetes. And when fat accumulates, we know it's pro-inflammatory, pro-thrombotic, pro-insulin resistant. I'll not go into all these details. Now, see this, some people believe maybe it's true only for Westerners, not for Indians. No, 44% of diabetes and 23% of cardiovascular disease in India can be attributed to overweight and obesity. And even if the intra-abdominal fat is high, even if a person is non-obese. So look at that. So for Indians, still, obesity is one of the most important factors for type 2 diabetes and cardiovascular disease. And even if someone is not obese, the chance for intra-abdominal fat is high. So we know that it is pro-thrombotic, pro-inflammatory, produce a lot of cytokines and cause a lot of complications. And by reversing obesity, all these unfavorable factors can be brought down and diabetes can possibly be reversed. And diabetes reduce the risk of developing diabetes by nearly 60%, reduce the risk of blood pressure by nearly 66%, and heart attacks and stroke by nearly 60%. And it is not that it takes quite a long time to achieve that. No. Fasting plasma glucose can normalize within 7 days of a low-cal diet. And there is a 30% decrease in hepatic fat in the first 7 days. And that is probably sufficient to normalize the insulin sensitivity of liver. And in 8 weeks' time, the glucose-stimulated insulin secretion returned to normal in pancreatic fat content, fell over 8 weeks, and beta cell function improved. All this if the person can be given a very low-calorie diet. So storage of liver fat can occur only when the daily calorie intake exceeds expense. So that is why it is very important for us to tell our patients that how many calories you need a day. So irrespective of whether it comes from carbohydrate, protein or fat, the first question that patients should be made aware is that how many calories they actually need a day, because if they are going to exceed that calorie, then fat is going to accumulate. And then sucrose is not good. Okay. So having known that type 2 diabetes is not for life, there are increasing global acceptance for that. So this is a statement by WHO. Energy restriction through a very low calorie diet can lead to the reduction of symptoms or even reversal of hyperglycemia typical of type 2 diabetes. They quoted a study from Barbados. I'll not go into the details. There are a lot of trials. Look ahead, then the Predimed, Direct we already discussed, and lot of dietary interventions are gaining popularity. And this is a study from Netherlands. This is our own study where we showed that with 3 months adequate dietary intervention, 86% of our patients reduced some weight, and 72% of our patients could either decrease or stop their medication. So that is a huge revolution coming from various approaches. And now, if we don't go for this intense measure, let's see what will happen. Now, if we are going by the standard care, only 0.23% of patients will achieve remission. So the status quo approach will not reverse the health crisis of diabetes, and we have to think out of the box. We have fairly large evidence to tell that reversal is possible. And now let us see how it can be done. So first we need to know that two things are very, very important for the human body. And the first thing is physical activity. Exercise is very important. I know that there was a detailed discussion yesterday, so I'll not go into the details. Suffice to say that without 30 to 45 minutes of aerobic exercise a day, any day is incomplete. So that's so much part of our physiology that 30 to 45 minutes of aerobic exercise every day is essential. Maybe we can add that with anaerobic exercises like strengthening exercise twice or thrice a week, or maybe even more, and the flexibility exercises. But I think what is most important is the activity of are the activities of daily living. I'll just quote one example. If we sleep for 1 hour, we spend around 50 calories, 50 to 56. If we sit up, we spend around 70 to 78 calories. And if we just stand up for 1 hour, we spend nearly 125 calories. So that is why it is important to incorporate such healthy habits in our day-to-day life. That means instead of sitting and watching TV, someone should maybe walk and watch, or walk during telephone, take the stairs, and so on. So we should encourage our patients to do as much physical activity as possible and try to achieve 7 to 10% of weight loss. Now, when we talk about food, there is independent evidence that fruits, vegetables, and probably legume consumption is good. This is from the Pure study by Dr. Youssef et al. And they told that there is a lower risk of non-cardiovascular and total mortality. So irrespective of the calories, irrespective of the carb content, high consumption of fruit, vegetables, and legumes per se are very beneficial. There are various types of eating pattern: Mediterranean diet, vegan diet, low fat diet, low carb diet, very low carb diet. So, but let me just summarize in 2 lines. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated most benefits. So obviously, if you take more carbs, you will have more glucose. If you take less carb, you will have less glucose in your blood. It's as simple as that. So the best method to bring down the postprandial hyperglycemia is to reduce the carbohydrate intake in food and emphasize on non-starchy vegetable, minimize sugar, and choose whole food. Now, often people say that, okay, I asked my patient to diet, and probably he is doing a good diet also. He has lost some weight, but still there is no remission. Why? This slide answers that. Now, there are 2 types of interventions: therapeutic intervention and subtherapeutic intervention. So, if a patient has to actually go in for remission, he has to reduce substantial weight. So, you see here, the weight loss in all the therapeutic studies where they could achieve an overall remission of nearly 50% was much higher compared to the weight reduction in subtherapeutic studies. So that means a patient should be encouraged to reduce at least 10 to 15 kilograms of weight, at least more than 10 kilogram of weight, if he has to achieve remission. Fine. Now, reduced carb means reduced blood glucose, and dietary fat is not considered to be as bad as what it was thought to be. So maybe we go a little liberal on that. And Jason Fung recently told that it is just not the energy intake and the energy output, but also the insulin levels which determine how the fat stores would be. So along with reducing energy intake and increasing energy input, we also need to keep the insulin levels low in our system if we are not to accumulate fat, and that can be achieved by maybe a very low carb diet and maybe methods like intermittent fasting. So we will follow what's very clear. So I think two things are most important. One, how many calories we need a day, and that is, if a person has to reduce his body fat, he should be put on 20 to 25 calories per kilogram per day, and for a normal weight person, maybe 30 calories per day. And the second question is, where should these calories come from? Maybe less than 50% should come from carbohydrates, and that's the most important statement. 20% from proteins and 30% from fat. The planetary food plate also tells that this is the global food plate. This is the conventional food plate, which says that fill half your plate with fruits and vegetables. The other half should be proteins and half should be grains, and 10% can be dairy products. So a healthy balanced diet means a lot of fruits, vegetables, whole grains, pulses, seafoods and nuts, and to have less red meat, processed meat, sugary food, drinks, refined grains like white bread. So I'll summarize by saying that reversal of obesity can lead to reversal of diabetes, and reversal of obesity doesn't necessarily mean that the patient has to be huge. And when you reverse obesity, it is also important that the patient should be encouraged to achieve maximum weight loss, target at least more than 10 kilogram weight loss. Consumption of good food is essential, because not only that it gets away with these diseases, a good food, especially consisting of lots of fruits, vegetables, can actually bring down the chance for cardiovascular risk also. And carbohydrates have to be limited. Fat concepts are changing. Remission of diabetes is possible, and it is high time that we move beyond the standard care to achieve remission. So there are many interventions coming up, and we also are trying to achieve that in our own little and humble ways. So thank you once again, Dr. Sabir, for this very kind opportunity. And I think I am left with 1 or 2 minutes in my 20-minute schedule. And maybe we'll take up questions now or later, as whatever the chair pleases. Once again, thank you very much for this opportunity.
Thank you, Dr. Sreejth. Am I audible?
Yes.
Am I audible? Thank you,
Yes,
Dr.
sir.
Sreejth, for the wonderful presentation. And actually, it's a new concept, and I know how busy you are. Are you going to stay back till the end of this session, or are you leaving early? If you are leaving early, you can take questions right now.
Whatever you wish, Anna, I can't question your authority.
I know that sort of time pressure you are having. So if you are happy to be here for...
Better
No problem.
can stay back, sir.
I'll stay back.
Okay, sir. Thank you. Thank you.
Then Sunil, please introduce the next speaker and lead the session. Sunil, Dr. Sunil.
Okay. After that fantastic session by Sreejth and Kumar sir, we'll move to the next topic. And the next topic is going to be dealt by a renowned physician and academician, Balachandran sir. He is from Dr. Nayer's Hospital, Kollam, and he is a very, very renowned academician. He is from Kollam, and he has been awarded the FICP, FACC, and so many degrees and fellowships, and he has been elevated to the Faculty of Medicine and Diabetology of Newcastle University, Australia, and he is a regular speaker in various diabetic forums also. Over to you, sir. And the topic sir going into deal is the cholesterol, good, bad, and ugly. Over to you, sir.
At the outset, let me thank Dr. Shabir, Dr. Deepa, Prashov, the organizers, and Dr. Mohan Nair and Prashov for chairing the session. And I am very unfortunate to being sandwiched between two renowned speakers. One is Sreejth on one side and Jothydev on the other side, and Ramachandran is going to follow. So my topic is on cholesterol. It's a very burning topic. What I'm going to, because we have been seeing a lot of, if I'm not audible, if the slide doesn't move, please inform me. Lot of WhatsApp and social media messages about cholesterol is good. You can eat any amount of fat. So my talk has nothing to do with the movie, famous movie acted by Clint Eastwood and Eli Wallach. So there is a report in Scientific American. Don't stop worrying about cholesterol. And you can have unrestrained consumption of French fries and pizzas. And CNN said that cholesterol in food is not a concern. And he's a pro-cholesterol anti-statin lobby by Chris Kresser. Diet heart with cholesterol and saturated fatty acid are not the enemy. All these things happened after the book which was published, which is called as The Big Fat Surprise by Nina T. Cole. It was considered as one of the best books in 2014 by Forbes.com, Wall Street Journal, Economist, one of the 10 best book and best-selling books. You can download this book in Kindle and then read it and forget it. And this is the book which has changed the outlook of so many people, and people started eating, and they are not controlling the diet. And there's another person who is the protagonist of cholesterol and an anti-statin campaign is the Mercola. You can go to the site and see many number of his papers. All these things, 40 trials to determine whether lowering cholesterol level can prevent heart disease. Australian Aboriginals have lowest cholesterol level, but the highest rate of heart disease. Cholesterol levels in the European countries, especially, was very high, but the death rate was low. So hence, cholesterol factor is of minor importance as a risk factor in cardiovascular disease. So that is another. It's the most important is the hypertension, obesity, diabetes, and insufficient physical activity. But all these things have been changed. They've been proved after the Interheart study, where definitely the cholesterol forms the major cardiovascular risk factor for myocardial infarction. So the 2015 US DA, that is Dietary Guideline Advisory Committee, came with cholesterol is not a nutrient of concern. Saturated fatty acid is not harmful. Eggs can be consumed in any amount. You can see that the DGA statement concluded there is an insufficient evidence to show that restricting dietary cholesterol lowers the low density lipoprotein. And cholesterol, saturated fatty acid is not a nutrient of concern for overconsumption. And stop demonizing saturated fatty acid, because there is no significant evidence for concluding that dietary saturated fatty acid is associated with an increased risk of coronary artery disease. There are a lot of papers, thousands of papers in the literature, both peer-reviewed and non-peer-reviewed journals, and supporting cholesterol intake and eggs intake and saturated fatty acid intake. All of them, the proud sponsors are these three. And many more nutritional and food companies are also have conflicts of interest. So, but one thing you must understand, cholesterol is required by the body. Every animal cell produces cholesterol. Acetyl coenzyme A is converted to mevalonate and several steps and 20 odd steps and goes to by HMG-CoA reductase into cholesterol. It builds mammalian membrane fluidity, neurons, myelin sheath, sperm cells, steroid hormone, fat-soluble vitamin, bile, antioxidant. So many dietary products contain cholesterol. But one thing we all must understand, the body produces 1,000 to 1,500 milligram of cholesterol. Whatever the body needs it produces. And it is recycled also. And the free cholesterol is present only in a very small amount. It is daily present as lipoprotein. The food cholesterol is different from blood cholesterol. Don't confuse fat with cholesterol. There are good fats, there are bad fats. When it's sitting on your plate, it is just a plain cholesterol. It becomes good or bad when it's packaged into particles called lipoprotein in your bloodstream. According to lipid hypothesis, since cholesterol is transported around the body inside the lipoprotein particles. The cholesterol, the conventional wisdom, when you estimate cholesterol, it indirectly tells you the estimation of LDL particles. So mostly about 80% to 85% of the people, possibly even low concentration of HDL. So both variations strongly associated. What is more important is the LDL particle numbers. So in the meta-analysis of over 60 trials, higher intake of saturated fatty acids were associated with the increased risk of LDL and decrease in triglyceride. Although saturated fatty acid increase LDL, many reduces the LDL particle numbers. And the Cochrane-based database said stroke, total MI, non-fatal MI are replacing saturated fatty acid with polyunsaturated fatty acid reduces the coronary artery disease events by 14%. The fat it matters, the long chain fatty acid and short chain fatty acid, what the fat you take is more important. We all know about the various fatty acids and monounsaturated fatty acid, metabolically the best, elevate HDL and lower LDL, olive, mustard, groundnut and ginger. What is more harmful is the trans fatty acid, which produces various types of metabolic abnormality as well as risk of Alzheimer's, cancer, obesity, etc. So in the omega fatty acid also you have N6 and N3. N6 is pro-atherogenic, pro-thrombotic, pro-accident, whereas N3 is less atherogenic, less thrombotic and less antioxidant activity. We know the saturated fatty acid and cholesterol is 87%. Whether it is good or not, it is harmful in excess in producing the atherogenesis. Whereas PUFA safflower oil, it is PUFA content is very high. So what the N6-N3 ratio is more important. Safflower oil has got a very high ratio. If anybody takes a sunflower oil or safflower oil, cornflower oil, only it is very harmful. So there is a need for mixture of the oils. What is more important is the amount of fat in our diet. We have what is called as invisible fat intake in different states. A lot of invisible fat, around 20% of our diet contains invisible fat. So you don't need to substitute fat at all in the diet. From excess fat, diabetes and coronary artery disease begin. From excess fat, diabetes and coronary artery disease die. So from 2015, we have come to 2020 dietary guidelines. We're a little more softer. It said that limit calories from added sugars and saturated fatty acid and reduce sodium intake. Take a better saturated fatty acid. The saturated fatty acid is non-harmful saturated fatty acid. That's it. So a fat-free, low-fat dairy product, including milk, yogurt, and cheese, and fortified soya beverages, healthy eating pattern is important. And reduce saturated fatty acid and trans fatty acid. That's a message by the 2020 guidelines. The American College of Cardiology and Heart Association came in 2013 stating that they were doesn't want to commit. They said that dietary cholesterol does not influence serum cholesterol, but excess is a nutrient of concern. Hence, the conventional wisdom says that dietary cholesterol increases the risk of heart disease and type 2 diabetes. Only herbivores get atherosclerosis. Man and human beings are herbivorous. We have a different teeth. We have an appendages are different. Intestinal tract is long. Body cooling is by sweating. And all practical purpose, we human beings are herbivorous. This man is the W.C. Roberts. He is the editor of the JACC for more than 10 years, president of the American College of Cardiology, staunch supporter of anti-cholesterol campaign, and did a lot of research on atherosclerosis. He said that atherosclerotic plaques are easily produced experimentally in herbivores. Cholesterol is present in experimentally produced atherosclerotic plaques in human beings. Societies and subjects with high serum cholesterol and LDL have higher frequency of atherosclerotic events. It is a 7-country study. He also said the only way to produce atherosclerosis is to feed them with high cholesterol and saturated fatty acid. No one has produced atherosclerosis by experimentally increasing high blood pressure, diabetes, or blowing smoke or stressing the animal. All the multifactorial origin, diabetes, smoking, obesity, secondary exercise of atherosclerosis is not acceptable when cholesterol level is less than 150 and LDL is less than 60. Even the inflammatory hypothesis is not acceptable. So you need a level of LDL cholesterol of plasma of 25 milligram would be sufficient to nourish the body cells. What you need is only 25 to 50 milligram of LDL to keep your requirement. You don't need more than that. So if you look at the neonates, they are only ranging from 15 to 30 milligram of cholesterol. So it is most important to the endothelium. Dysfunction is produced by smoking, hypertension, and diabetes. Even if lipid is bad, atherosclerosis won't occur if endothelium is good. People with normal lipid can still have atherosclerotic cardiovascular disease if endothelium is bad. We have seen plenty of people coming to us and asking me, sir, my cholesterol is low, my LDL is low. Why should I get a heart attack? Why did I get a heart attack? This definitely is endothelium is bad. more than 30 billion population data from various studies that high LDL causes MI, strokes, and death. Now that we have the Atherosclerotic Society consensus panel last year said that LDL causes atherosclerotic cardiovascular disease. There is absolutely no doubt about it. And they also went further and said that atherosclerosis will not develop if LDL is less than 50 milligram. And start rearing your children right from the younger age group to keep the LDL level around 50 to 60. Carbohydrate is a main culprit. Eat more fat and less carbohydrate, bring it to 45%. The risk of heart disease, every additional 100 milligram of dietary cholesterol, serum cholesterol increases roughly by 2 milligram. Consuming 1 to 3 eggs per day would increase LDL by 4 to 12 milligram per deciliter. We have cohort studies where 22% increased risk of all-cause mortality and 28% higher risk of heart failure every people who eat more eggs. And in a study that tracked about 37,851 men, 80,882 women, and 14 years, they said that high incidence of coronary artery disease, 49% higher risk in women, and consume more than 1 egg. And a physician health study, a women health study, all have proved that an eggs per week, 7 eggs per week, increase the risk of coronary artery disease. So they gave all the scientists to comment on the 2015 dietary guideline. They said that 2000 dietary guideline conclusion that dietary cholesterol is not a nutrient of concern, is not based on the best scientific evidence available. And the DGAC has misled the public to believe that a healthy dietary pattern could contain an unlimited quantity of eggs. So contrary to DGA's decision, AHA President 2017 said that there are a lot of media have going on and dietary cholesterol. He said that dietary cholesterol is very much a nutrient of concern because it increases the LDL, a well-established risk factor for coronary artery disease. This was published in American College of Cardiology, and the AHA president continued to say that weight of evidence that plant foods are better with low saturated fat. Coconut oil is 82% saturated fatty acid, and studies show it raises LDL bad cholesterol as much as butter. And American Heart Association and ACC does not like coconut oil. They recently published this year, Association of Dietary Cholesterol or Egg Consumption with the increased incidence of cardiovascular mortality, published in JAMA. And now the 2020 American Heart Association and ACC have come to a compromise stating that dietary cholesterol does increase low-density lipoprotein cholesterol. But saturated fatty acid is not that harmful, but it is better than the carbohydrate. Hence, they said that saturated fatty acid to the consumption is to be reduced, but choose the amount of type of saturated fatty acid. That is more important. In Indian real-world evidence that only 2.8% of the population having LDL less than 50 milligrams. So the PURE study, which was published last year, though it was not considered as a scientific study because it's mostly of a questionnaire-based study, and it was more than about nearly 135,000 population. As Dr. Sreejth said, that fruit and vegetable legume intake was good, but the controversial factor was high-fat diet. There is 23% reduction in mortality. And another controversial factor is that LDL does not produce major coronary artery disease, especially in Indians, are less important. And a high-fat, low-carbohydrate diet is beneficial. Saturated fatty acids is better than carbohydrate. This is the outcome of the study, but this was not well discussed. The whole PURE study was not very well discussed in scientific forum. We have been taught that all these years, the conventional wisdom that good cholesterol is good, but it is not so. High amount of HDL is bad. We have a lot of papers where extremely high density lipoprotein cholesterol is paradoxically associated with higher mortality in men and women. So more important than the cholesterol discussing, it's very difficult to conduct a study on cholesterol and eating pattern because there's so much of difference in genetic, racial, ethnicity, geographic variations. The people in Pima Indians, the dietary pattern is different from from other Chinese are different, the Japanese are different, Asian Americans, Asian Indians are different, migrant Indians are different. So we have a lot of ethnic variations. LDL, low or high, both small dense LDL is matters. And LDL metabolism and PCSK9. The LDL is most important. How much LDL is being internalized by PCSK9 receptors are more important. LDL moderate is okay, but high and low are bad. Non-HDL particles better than LDL alone. Total cholesterol and HDL ratio is important. Triglyceride and HDL ratio is important. ApoB, ApoA ratio, invisible fat in the diet is another important. You don't need to substitute fat in the diet at all. But about last year, there was a British Journal of Hospital Medicine. There is a big article on statin wars. Have we been misled about the evidence? But there is a fitting reply given by the European Heart Association stating that anti-statin lobby strikes again. Time to keep the record straight. And it is a very good article. One can read that. And they all went on saying that negative statin-related stories decreases persistent and increased myocardial infarction and cardiovascular mortality, increase the risk of myocardial infarction when you discontinue the statins. So there are a lot of papers in the press against and for statins. And why there is a conflict of interest for statin alone. There are so many drugs, acetamide is there. Fenofibrate came and did not produce a much beneficial effect. And nicotinic acid went out. And PCSK9 has to take up. And there are a lot of triglyceride inhibitors like ApoE3 inhibitors and CETP, that is cholesterol ester transfer protein, toxicrabim, miserably failed. Angiopoietin-like protein inhibitors and did not reduce triglyceride. Lipoprotein A little inhibitor and ApoE Milano came with a very big bang, but it did not raise the HDL, and raising HDL did not produce reduction in coronary artery disease or acute coronary syndrome. So, but statins are there, concentrating only on the statin. There's a big anti-statin lobby. The ACCHA 2018 guidelines said that clinical atherosclerotic cardiovascular disease reduce LDL-C with high-intensity statin therapy or maximally tolerated statin therapy. So now we have cholesterol. Can cholesterol be used to fight COVID-19? SARS-CoV-2 infected cells began to accumulate large amount of lipid droplets. Lung cells are not designed to hold fat, which could explain some of the severe damage to the lungs. The virus is dependent on glucose uptake, cholesterol production, fatty acid. So statins and fenofibrate are being tried. So we have been learning medicine only from standard textbooks and standard journals, not from various social medias. Please use the media to report positively on statins and cholesterol lowering for the benefit of your patient and society as a whole. So to conclude my talk, the good aspect of cholesterol is essential nutrient required by every single cell of the body to function properly. Cholesterol is necessary for every steroid hormone which is synthesized from cholesterol, including sex hormone and adrenal hormone. Cholesterol helps to convert sunlight to vitamin D in the human body, which is very important for the body, called sunshine vitamin, boost our immune system. And the bad part is the conventional wisdom lipid hypothesis stays. The bad part is mainly about propaganda. And the conventional wisdom lipid hypothesis stays. Dietary cholesterol is definitely a nutrient of concern. LDL of 50, there is no atherosclerosis. Saturated fatty acid is still bad, but choose your saturated fatty acid. Fatty acid from eggs and a high meat are bad. Trans fatty acid is the worst. Repeated frying oils. Saturated fatty acid should be replaced by PUFA and MUFA. Replacing saturated fatty acid with carbohydrate is not good. Carbohydrate itself, we have good carbohydrate and bad carbohydrate. Reduce it from 65% to 45%. Coconut oil is still a nutrient of consumption for overconsumption. You can add coconut oil with other oil, but the over controversy continues. Invisible fats form 40% of the Indian diet. If endothelium is good, no atherosclerotic cardiovascular disease. The ugly part is influence of food industry on nutrition. Anti-cholesterol and anti-statin lobby has made a big havoc. Irresponsibility on the part of social media, internet, Facebook, WhatsApp create confusion in the mind of common man. Doctors also forward such messages without giving a fitting reply. Plenty of reports were increase in sudden death and coronary artery disease when statins are stopped. In Greek mythology, we have three gorgons. Gorgons means demons, Steno, Uriel, and Medusa. We have one is saturated fatty acid, another is small dense LDL, non-HDL, another is high carbohydrate. Thank you.
Thank you, Balandran sir, for the wonderful presentation. It's a very highly controversial topic, and you have made it very clear as to where the physicians and the doctors are to be. And next we are going to take questions only at the end. And once again, we have a very eminent academician to follow. Recently, only we had a great academic feast in Trivandrum, from Trivandrum. That was the JPEF annual convention. This year, we were very much concerned whether this JPEF annual convention, this program, all this will happen or not. And Dr. Jothydev has clearly shown that it is possible, even in this COVID era, to go ahead with all these academic events. And they have done it wonderfully well. Now to be followed by Dr. Sabir here. Now I request Dr. Sunil Prashoth to introduce our next speaker, none other than Dr. Jothydev Kesavadev, who is very familiar to all of us.
Thank you, sir. So the next talk is going to be dealt by Dr. Jothydev Kesavadev, sir. He is the chairman of Jothydev Diabetic Research Center, Trivandrum, Kochi, Attingal. He is vice president of Aero, and he is a fantastic speaker. We all know him. And he has got several fellowships, and he has done orations and lectured in many forums in India and abroad. The topic is a very, very interesting one, and we all know that of late there has been so many unconventional and non-evidence-based therapies, especially in the field of diabetes, has been happening. And Sir is going to talk about the perils of non-evidence-based therapies in diabetics practice in this COVID era. Over to you, sir.
First of all, thank you very much, Mohan Nair, sir, and my dear friend Sunil Prashoth for the nice words, and congratulations to Dr. Shabir for this very successful event. And thanks for inviting me too. So as rightly said by Mohan Nair, sir, we were very successful in conducting a JPEF this year, and we all believe that education should continue. And so let me now proceed. And my title is on perils of non-evidence-based therapies, especially during this COVID era. So these are very troubled times for all of us. So I thought that I will start with a lighter note. The union minister who originally claimed puppet for a COVID cure has ultimately tested positive for COVID. And this is another very interesting page from Wikipedia documenting millions of fake COVID-19 treatments, millions. So when we people in modern medicine are busy with exploring newer investigations for COVID and exploring newer therapies, including vaccines for COVID, the guys in other so-called specialties or branches in medicine, they are busy propagating these unproven remedies. And this is from Africa, an unproven herbal remedy against COVID-19, now proven to fuel a drug-resistant sort of malaria. And this is a warning from the scientific world. And we, the Kerala guys, are also now very popular. So we are now infamous, very infamous. And this is again in the international media. Our own self-proclaimed naturopath was arrested in Kerala, and he has got a position now in the COVID-19 page. So very interesting, very interesting. And the question is, why is this happening? Why is this happening? So we have been listening to Balachandran sir, we have been listening to Dr. Sreejth and Kumar, and there are some similarities even in this presentation. Why are these unproven therapies still popular? So with COVID-19, there is anxiety all over, and this makes people more willing to try anything which is available, which gives them a sense of control of the situation. And many false claims are being circulated widely in WhatsApp, Facebook, and other social media, including YouTube. And some of these are claimed to be even from the World Health Organization, UNICEF, and so on. So the ordinary people and even the educated lot believe this. What are the effects? What are the after effects of such false propaganda? it ultimately gives a dangerous false confidence, increasing the infection rates. And people will go out searching for those remedies because these remedies are not widely available. And this encourages people to break the stay-home orders. And hundreds of people have died from fake COVID-19 treatments. In India, it can continue. But see, in the United States, the Environmental Protection Agency, this is one example, they have issued stop sale orders to Amazon.com and eBay regarding the third-party goods falsely claiming to kill COVID-19, threatening fines up to more than $20,000 for every sale of the product. Very brave effort. And now moving on to those unproven therapies in diabetes. And this is the news on a 13-year-old who died after being told not to take insulin. And now the herbalist is headed to jail. So this is the heading in Washington Post. In India, of course, this happens very commonly, but headed to jail rarely or seldom happens. Very unfortunate, very unfortunate. And I'm pretty sure that all of you, Mohan Nair sir, all of you will have hundreds of such experiences. And this is acupuncture and how fatal can be acupuncture. How fatal can be acupuncture? This is a guy around 26 years old. He used to be the young leader for diabetes at the International Diabetes Federation. And he has attended our type 1 diabetes educational events a couple of times. He was never our patient, but his primary objective was to propagate that insulin is absolutely essential in type 1 diabetes, and in the absence of insulin, people will die. But see what happened? He went for an acupuncture therapy in Cochin, and within 24 hours, he was carried to this hospital, and he is also a close friend of mine. And within hours of admission, he died in the hospital. His sugars were more than 1,400 with diabetic ketoacidosis. And I followed up the case, and I wanted to sincerely do something. But ultimately, I found that very, very close relatives were involved in pressurizing him to get admitted at the acupuncture hospital, where he was forced to stop. He was not given, he was denied insulin. He was begging for insulin, but nobody could provide him insulin, and he died. So this story continues. This story continues. And the individuals with diabetes are more prone for adopting complementary and alternative therapies. And almost every fourth patient with diabetes, they use complementary and alternative therapies and medications, the so-called medications. And this is one study we did in more than 2,800 subjects and on why they have discontinued statins. So this is a population survey which was along with the diabetes screening program, Dive Screen Kerala. And initially we thought that the physicians are, of course, they are prescribing statins, but our patients are discontinuing. And these are because of many, many reasons. And initially we thought it's because of financial reasons. Then we found that they were afraid of medication side effects such as kidney and the liver. And then many thought that why should I be unnecessarily on an extra therapy? And this has resulted in a surge of coronary artery disease in our state. Because every week or so, there will be an adverse report on the side effects of statins. So why this paradox? Why this paradox? The unscientific therapies are injuring the liver and kidney, and our therapies never injure the liver and kidney. And then why this paradox? So let us explore the reasons. This is a recent publication. I would say that this is a heroic attempt by a group of doctors from our own state, which was published in Indian Journal of Gastroenterology. And they have done histopathological examination of those patients who had severe liver injuries secondary to Ayurvedic and herbal medication intake. Of course, I said it was a heroic attempt because the consequences are more lethal, which many of you are aware. So these were the methods of the study. 33 patients who were suspected to have Ayurvedic and herbal medicine, and this is DILI, drug-induced liver injury. So the samples were analyzed for heavy metals and hepatotoxic volatile organic compounds, HPOCs. And those ingested were mainly from unregistered traditional healers, but many were from reputed firms. And they did the liver biopsy, and they found that there is massive hepatic necrosis as seen in this picture. And this is one example of medication from a herbal, a traditional healer. And this is submassive hepatic necrosis. And this was from a popular Ayurvedic product, multiple ones, which was even advertised for joint pains in the media, and so on. So here, the result says that the duration of the drug intake was just for 28 days, and some patients died. Arsenic and mercury were significantly associated with death, and these hepatotoxic volatile chemicals were detected in more than 70% of the samples. And a couple of years ago, in 2017, we published a couple of papers on unscientific therapies in diabetes, and also wrote a chapter in a textbook. So I will briefly go through the CAM in diabetes. So what is the definition of complementary? So these are the therapies that are used along with conventional treatment, whereas alternative therapies are used in place. So you substitute and you stop it. So there are many of our patients who will stop modern medicines and they will go only for the herbal remedies. So that is alternative therapy. So the ADA position statement doesn't recommend the use of any of these therapies unless their safety and then efficacy has been established. It is very important that you have to establish not only the safety, but also the efficacy. The complications are multiple. They can alter the PK/PD properties of the conventional therapies when they are used as a complementary one. And in case of PK interactions, it can alter the absorption of the product, distribution of the product, metabolism and excretion, and it can interfere with the intestinal and hepatic enzymes. And in pharmacodynamic interactions, the herbal remedies can interact with the same target molecule. So when there is synergy, it increases the toxicity. Whereas when there is antagonistic interactions, it can result in a reduced efficiency or efficacy of the product. So these are some of the common concerns with the popular Ayurvedic medications which are marketed for diabetes. There is variability of the same product from one lot to the other. There is absolute lack of standardization. There is misidentification. There is mislabeling and contamination. So this is a long process, and the discussion itself will take more than an hour. So I will be very brief for the sake of time. An example of a contamination of a herbal product, Aristochia serpentina for Stephania tetrana, which resulted in urothelial malignancy and several deaths. The Chinese herb-induced nephropathy in quotations. And the biological complementary therapies for diabetes, cinnamon, gymnema, aloe, fenugreek, and so on. And then a brief discussion on fenugreek. We are also conducting an RSSDA supported research on fenugreek in our center. It contains coumarin constituents. It increases the effects of anticoagulants. So need to be very careful when it is given along with anticoagulants. Enhances the effect of our sulfonylureas, gliptins, thereby increasing the chances of hypoglycemia. Look at this FDA notification, quite interesting and widely popular in our country, but nothing happens in our country. So this is about a Chinese herbal product, Liquang 4, dietary supplement capsules being marketed online in several parts of the US for diabetes. And they found that there is a contaminant, none other than glibenclamide, glyburide. So the Indian herbal products claiming to be anti-diabetic, they also have been reported to be contaminated with drugs such as glibenclamide. We know the fact, and a large percentage of medications from Ayurveda, both US and Indian manufactured, they have lead, mercury, and arsenic. Lead, mercury, and arsenic. Several Indian herbal medicines were found to have lead toxicity in diabetes. And there are such therapies being even propagated by the modern medicine doctors. So this is one therapy which has been very popular in Kerala from northern part, and that is a sweet therapy being propagated by a modern medicine doctor for stimulating the pancreas, the sleeping pancreas, and the population people are going in groups. And this is an analysis of 25 patients that we have done. And this is the average age, and this is the duration of therapy, 6 to 8 months. That is the average duration of sweet therapy. And this is before therapy and this is after therapy. Look at the A1C, 7 versus 11, and spot 23 versus 245. We do have laws in our country. And this is very old. In 1954, the drugs and magic remedies. And this is one interface from the same Drug and Cosmetic Act, and it says that where diabetes is also in the list, that you should not propagate a drug as a prevention or cure for the following illnesses. I am very particular that why these scientific therapies are existing. So we need to explore why are these scientific therapies existing, and these are the probable reasons. Many of us have very close friends or even relatives who are involved in this. So we don't want to deliberately hurt them or probably invite trouble. Evidence on hepatic toxicity, renal toxicity, they are not getting published in the way it need to be published. And there is a subgroup of modern medicine doctors who believe that these therapies are good and efficient. But ultimately, the reason could be why it is still existing could be the fear, especially by the modern medicine doctors. But recently, I know that there are a group of young doctors very active in the social media from our own modern medicine, from Indian Medical Association. And this is something which is so comforting for us. So they are open. So what can we do? What can we do to stop this? And these are again the international recommendations. You cannot just tell the patient to stop it, because that is their own belief. Respect his health beliefs. And we need to address in an unbiased manner. But I will say that there should be no experiments with these unscientific and unproven remedies, both for diabetes and for COVID, especially during this pandemic era. Very, very important that we should be instructing our patients. And these unscientific remedies are probably going to exist, because diabetes is a very, very ancient disease, and the claims for cure can easily attract even the educated lot, and unproven therapies will exist. And this is a recent paper from a group of doctors, including me, initiated by Dr. Mohan from Chennai, on diabetes and coronavirus disease, what to do and what not to do, and the precautions. I would like to start with a cartoon which we created a couple of years ago. And this is in 2005, when he has stopped all his medications and adopted the insulin plant. So he's very excited. I saved a lot of money. And this is 10 years later, when he is blind, when the kidney is gone, and all the wealth is gone along with a limb amputation. So that is the fate of unproven therapies. So thank you very much. Thank you very much. And congratulations to my dear friend Shabir for this very, very successful event.
Yeah, all the three speakers are here. All the three were excellent topics and reasonably controversial as well. And I don't find any questions in the chat box. So questions, please. Or is it that everyone is convinced of the need of whatever had been told?
No, to initiate the discussion, let me ask Dr. Balachandran sir one doubt. Because when we talk about LDL cholesterol, actually, sir, it is being largely told that beyond LDL cholesterol, it is actually the size of the LDL cholesterol also which matters. And our conventional way of counting the LDL cholesterol together may not be very scientific. and large buoyant LDL particles may not be actually harmful. So, what is your take on that? Should we subdivide the LDL, and should we dissect further? Or should we classify the whole LDL together?
The estimation of LDL cholesterol doesn't estimate the LDL small dense particles. It is very difficult. Estimating the LDL-C, it's very LDL small dense LDL is very difficult, and it is not being done routinely. It may be in some research labs. So, if the LDL is associated with high triglyceride, you can take it for granted the small dense LDL also is high. And second is in diabetic population, we all know the LDL is normal. But the LDL-C percentage of LDL-C is very high, what we call as diabetic dyslipidemia, highly prone to develop atherogenic. More important is the endothelium.
Sreejth sir, we all know this in this COVID era, there are so many confusion among the people regarding the medications and treatment. And of late, we have seen this other systems of medicines coming and advising and giving drugs as immune boosters. In fact, there are so many confusion going around among the people, whether to, so many are asking these questions, whether we can take these medicines. And in fact, government is also involved. IMA may have their own opinions. What is your take on that, sir?
Yeah, in fact, I was surprised that Jodi missed the most controversial drug in his first opening slide. So this humbug about arsenicum album actually should end. In fact, I had written an article and I was about to put it up when all these controversies came. So I didn't want it to, get subdued in all these controversies. There is huge evidence from Maharashtra that this is sheer humbug which is going on. And in 2003, actually, what happened was there was this dengue flaring up in Trivandrum. And at that stage, this again, the homeo preventive drug was given widely all over Trivandrum. Those days, I was IMA secretary of Trivandrum branch. And then we undertook a small study. We went into SAT hospital and found out how many of those kids who were admitted actually took the preventive drug. Actually, they were giving it in all the schools also. And then finally, we found out that in the society, all those who took the preventive drugs, 18% of those who took and 11% of those who didn't take got dengue in the society. And in that SAT hospital admission, 46%, if I remember correct, it was an old study. Unfortunately, we didn't publish that. I'm just speaking from my memory. 46% of those who took, and I think 32% of those who didn't take were in the hospital. So then we conducted a huge rally here in Trivandrum, anti-mosquito rally. And that day, we got all the minister, chief minister, the opposition leader, everyone in one stage declaring that mosquito is our enemy. Kodugana Shatru. We conducted this thing. And last week, I was just glancing through my gallery, and I've taken I've taken a newspaper clipping, a photograph of a newspaper clipping, which was telling, where the health minister was telling that dengue is caused by mosquitoes, and the only way of control is by controlling mosquitoes. This may seem a small statement. I don't know whether you can see that, but this is a statement. I know it is inverse, but Kodugadashikaranam matramana pradhirodha margam, and it took almost 20 years for a health minister to say that to prevent dengue, you need to annihilate mosquitoes and not give these preventive syrups. So that is the state of affairs. I completely agree with Dr. Jodi that we need a huge movement for that. I am very glad that Jodi took up this topic and brought it out. I know, many people, including some of our doctors, Jodi rightly told, they will feel little disillusioned. Why this guy is talking against me? No, we are not talking against anyone in person. And when we put it in the FB also, many homeo friends will ask why you are why you are irritating us, and then they will go on propagating that this guy is a fake. And rightly, as Jodi told, many wouldn't like to venture into those controversies. So what we tell them is, this is not against you. You are destroying public health, and you cannot actually experiment on people like this.
then they quote some evidence. And one guy was telling, I appeared in a media debate. One guy was telling that, we gave all these medicines to many people in Pathanamthitta or Pandalam. We found it to be quite effective. Now we are going to ask the government and all the drug authorities to give approval. Then I told it is just the reverse. You have to first get the approval and then you have to give the drug. Now you are already giving the drug and then you are asking for the approval. And then you put the government in a tight spot where, government has to, what the health minister is saying is, I am minister of all departments, so I have to look after the other department also. No, you are minister of public health. You're not minister of modern medicine or any other system. So I think it is a huge issue here, especially in Kerala and in India. I don't want to ridicule any person, but then we have to stay for science. And this, what it produces is, why it damages it is because everyone thinks that I have taken the preventive medicine, I need not wear a mask, I need not maintain distance, and then it will be counterproductive. So IMA has told that there are many allegations, but there is absolutely no doubt that such unscientific systems have to go. And I'll go one step further. I'll say that the unscientific systems, and at least government money should not be spent for unscientific systems.
Thank you, sir. Hopefully, we all think in that positive way. One more question to Jothydev, sir. Sir was actually, in fact, showing an article in which Jothydev, sir, was one of the co-authors. It is a very, very informative article which very clearly says the scientific reasons behind why we should give insulin in moderate and severe cases and why to avoid some of the OHAs which are in the usual practice. And sir, it is high time that we need to educate the people regarding the importance of insulin and especially the control of diabetes. And in later stages, definitely we will have to go insulin. Your take on that, sir?
Yes, definitely, because insulin should be more propagated. And because of the sake of time, I am going to stop here because I can see Ravindra sir waiting over there. So thank you very much.
No, Dr. Jyoti, there is one question. What's your opinion on the use of vitamin C and vitamin D in this pandemic times? This question appeared in the chat box. I think it's from Dr. Sabir.
Yeah, I think there is quite scientific evidence to promote vitamin D, vitamin C, vitamin B12, and the zinc. And this is with respect to both the cell-mediated and B-cell-mediated immunity, both humoral and cellular immunity. And then there are some studies on endothelial dysfunction as well. And I did a recent lecture also on this. And from modern medicine, because we were discussing about unproven therapies, from modern medicine, we do have sufficient evidence. Of course, it is not for boosting the immunity, but these vitamins are related to immunity. And vitamin D, in a recent study from 20 countries in Europe, they have shown that more critically ill patients who were admitted in the ICU and more deaths were reported in those patients with very low vitamin D levels. And with high vitamin D levels, the survival rates were also higher. So there are still ongoing studies, including some clinical trials related to these three vitamins. So thank you, sir.
Thank you, Jyoti. I acknowledge the presence of Ravindran sir again. Thank you, Ravindran sir. But I have a small question again to Jyoti. It's a continuation of the previous presentation. It's about HCQ, and you have vouched for HCQ in several platforms. I have a question about people who already had a coronary event, who have undergone an angioplasty or a coronary bypass graft. Is there any contraindication or HCQ in such patients?
Whether it is working or not, honestly telling you, sir, I am also on HCQ because I'm taking hydroxychloroquine once in every 4 days. And I checked my own electrocardiogram and I discussed with the cardiologist as well. And the international protocol says that up to a QTC interval of up to 480, we can have it as prophylaxis. And it is again related to the same zinc that we have discussed, the virucidal effect, and also it has got something to do with the spike protein and its attachment to the functional receptor of the COVID-19. So it works as a prophylactic agent, and that probably is one of the reasons why it is still there in the ICMR protocol. Probably Dr. Sreejth will be knowing more about it. Anyway, personally, I would like to promote, but in those patients who already had a coronary event, we can go by the QTC. And maybe everybody can take it because it is a very, very safe drug, been there for more than 60, 70 years.
Any comments, Sreejth? Dr. Sreejth, any comments on that?
Actually, I don't want to trigger a controversy, so I think I'll not comment at this stage. Again, I'll say that probably we should go for proven therapies, and the only thing which is known to boost immunity against COVID, it's COVID itself. At this stage, we are waiting for the vaccine, so let's wait for that.
So thank you very much, all the three speakers. It was a session, and also thank you, Dr. Sabir Rasheed. Let us conclude this session. Thank you again.